Good afternoon, everyone, and thanks for joining us. I see by my clock that it is now noon, so I think we're ready to get underway. I am Anna Hoover. It is my privilege to be the co-director of the Systems for Action National Program Office here at the University of Kentucky. Also on the line are other staff members, including Ann Kelly, our very able program officer who makes this seminar series happen, as well as Lizeth Fowler, our excellent deputy director. I thank them both for all the work that they put into this series. Today we are very excited to be sharing with you some research in progress from colleagues in North Carolina. This falls within the Bridging Health and Healthcare portfolio, and it sort of really speaks to some of the emerging work that we're going to be doing through the new Systems for Action National Program, looking at the alignment of multiple systems to maximize outcomes. And so we are so happy today to be talking about integrating healthcare and public health to improve HIV early detection and control. Just a couple of housekeeping notes. First off, I'd like for you to have a look at the resources box in the upper right-hand corner of your screen. If you would like a copy of either the bios for the speakers or today's presentations, you may download them from there. And please do so. We will also be archiving this webinar, as we do all of the Research in Progress webinars, on our website. So please pay us a visit there to see all of the great work that has been coming through this seminar series for almost 2 years now, I believe. So moving along today, because we want to get right into things, I would like to go ahead and introduce our presenters and also go ahead and introduce our respondents who will be speaking after the presentation so that we can move seamlessly through the presentation. I'd like to start with Deborah Porterfield. Dr. Porterfield is a senior public health research analyst at RTI International in North Carolina and an associate professor at the UNC Chapel Hill School of Medicine. She has completed training in health services research, public health, internal medicine, and preventive medicine, and has 6 years of public health practice experience at the North Carolina Division of Public Health. Dr. Porterfield's work in public health systems and services research has focused on performance measurement in state and local health departments in cancer and diabetes with projects for CDC. An additional area of focus is integration between public health and primary care with past project work for ARC and PCORI. Joining Dr. Porterfield will be Dr. Christine Bevc, an epidemiologist research associate with the North Carolina Institute of Public Health at the University of North Carolina Chapel Hill School of Public Health. Dr. Bevc's work in public health systems and services research has focused on applying her expertise in social networks and social science research methods to better understand and improve interorganizational relationships and collaboration. Her research broadly focuses on organizational behavior, environment and society, and disasters, with past work for the Centers for Disease Control and Prevention and the National Science Foundation. Our commentators following the presentation today are Max Wilson. Dr. Wilson is the HIV/AIDS Program Coordinator for Northeast Florida at the Florida Department of Health. He worked as a researcher, college instructor, and academic department chair before becoming the prevention coordinator for the Florida Department of Health's Area 4 AIDS Program Office in 2007. He was appointed the statewide evaluation consultant for the HIV/AIDS program in 2008, with recent projects including providing evaluation for the Enhanced Comprehensive HIV/AIDS Prevention Plan in Miami and implementing a reproductive sexual health service line in the Department of Health in Duval. He also serves as the DOH Duval Part C Program Director for 3 years. We're also joined by Jeff Downey, who is a public health practitioner and educator from South Florida. He currently is the program manager for Ryan White Part A in Florida's Area 9 at the Palm Beach County Department of Community Services. He's also working toward a DRPH degree, and his research is a social network analysis of the HIV/AIDS service delivery network in Broward County with a focus on information exchange and interorganizational accountability. Again, Dr. Wilson and Mr. Downey will be responding following the presentation by Dr. Porterfield and Dr. Bevc. And with that, I will turn the mic over to Drs. Porterfield and Bevc.
Great. Thank you so much, Ms. Hoover. Good afternoon, everyone. On behalf of our team, I'd like to welcome you to this discussion of our project Integrating to Improve, Integration Between Healthcare and Public Health to Improve HIV Early Detection and Control. Thank you so much for your time today. Thank you for the Robert Wood Johnson Foundation as well as the National Program Office for supporting this work and for inviting us to present to you today. So here is a glimpse of our project team. It's composed of academic-based investigators and practice-based researchers from RTI, UNC, University of Florida, and the Florida Department of Health. We feel our team has a strong balance of both practice insight as well as research expertise in areas such as integration between healthcare and public health, social network analysis, and public health systems as well as health services research to accomplish the aims of this study. As Ms. Hoover indicated today, you'll hear from myself, co-investigator Dr. Bevc, as well as our community co-investigator, Max Wilson, and then Jeff Downey, who represents our community partners on the project. In addition, from this slide, I'd like to acknowledge our co-investigator, Lori Bolello from University of Florida, who's also director of the Florida Public Health Practice-Based Research Network. So a little bit about the background of our project. The clinical and public health issue that this project addresses is the suboptimal engagement in HIV care for persons with HIV/AIDS. After 30-plus years of the epidemic, it's estimated that 20% of persons with the disease are not aware of their diagnosis, and significant proportions of persons present at a late stage, experience delays in care, or do not remain in care continuously. What has been termed the HIV spectrum of care has become a popular and important way to characterize this problem. Although this simple diagram does not fully represent the complexity of persons moving between the states of, to the far left, being unaware of infection through screening and awareness, receiving some care, and to the far right, being fully engaged in care, and some have added to the spectrum, achieving viral submission. Nevertheless, this is a useful model of engagement that helps to depict the steps or flow of patients and also some of the relevant outcomes of interest. In terms of numbers, according to one estimate, of the 1.1 million persons living with HIV in 2006, only 79% were aware of their diagnosis. Of those diagnosed, only 75% are linked to care within 6 to 12 months, and only 50% are engaged in continuous care. The spectrum also seems to depict a single system of HIV care. Not shown, however, are the wide variety of organizations involved in the flow of patients and the complexity of those organizational interactions, and the fact that there is, in actuality, not a single system. One place in the spectrum where this may be particularly relevant is the step between diagnosis and engagement in care. Many persons with HIV are diagnosed outside the clinical setting and must be linked then to clinical care. Transition of care from one system, public health, to another system, medical care, therefore may be unnecessarily fragmented. Linkage isn't the only challenge. Gaps in all of these steps, testing persons at risk, identifying at an early stage, ensuring continuous care, also represent failures of this macro system to limit the impact of HIV infection on individuals. Relatively siloed federal funding may very well contribute to this fragmentation of the system. In addition to foundations, the major funder of organizations supporting education, awareness, and testing is the Centers for Disease and Control and Prevention, whereas the major funders of HIV care in the United States are Medicaid and the Health Resources and Services Administration's Ryan White program, which funds states, municipalities, and local organizations to deliver HIV care. Furthermore, there appears to be a gap between evidence for an ideal system of care for HIV and current policy recommendations. There is some information about organizational level best practices in linkage to care of HIV patients or early entry, retention, and care, the outcomes that we're most interested in. But there's no research on what or how organizations can work together to achieve these goals. Despite limited evidence, multiple organizations have called for integration or collaboration to achieve the goals. For example, the White House Office of National AIDS Policy National Strategy makes this recommendation: establish a seamless system to immediately link people to continuous and coordinated quality care when they learn they are infected with HIV. Also, CDC provides information to its grantees for developing community-based screening programs and recommends that linkage be provided as a minimum service, but detailed strategies that focus on patient-level interventions, such as case managers or linkage coordinators, without explicit acknowledgement of the underlying structure and importance of organizational relationships. The document also does not detail strategies to develop those collaborations or methods to determine whether organizations are partnering effectively to deliver care. Therefore, this project will attempt to gather evidence to address this gap and help to answer the big picture questions such as, what is the optimal structure of a system of care for HIV, and how can that structure be achieved? So we have 3 overarching project goals. The first is to examine how public health, primary care, and community organizations work as a system to identify, link to care, and provide continuous care for patients with HIV. As you can see in this first bullet, we have 3 outcomes of interest within the spectrum of care, and those are early detection, linkage to care, and continuous care. The second goal is to determine the organizational and system characteristics associated with delivery of continuous care for persons with HIV. We will use social network analysis methods relatively unique in the study of HIV and also in the study of any type of systems of care to achieve this goal. Importantly, we're studying HIV not only because of the population health significance described earlier, but also because outcome data at the organizational and eventually, potentially, at the community level is available. For this first study, however, as we'll describe later, of our 3 outcomes, only 1 continuous care outcome data is available and will be investigated. Finally, our third goal is to develop resources to improve the HIV systems of care based on study findings. Very briefly, we have a project logic model. This shows in a high-level fashion, first of all, that patient flow through the system of care. The white boxes through the center are essentially that spectrum of care with a little more detail and depict how delivery of screening services leads to diagnosis and linkage to both HIV care as well as other healthcare services, support services, case management. They're then leading to outcomes of interest of early diagnosis, early entry into care, continuous care, and subsequent outcomes of retention, adherence to medication, and viral suppression. Of course, in the comprehensive care of HIV patients, there are many other outcomes of interest, but this framework builds specifically on that spectrum of care shown earlier. The blue boxes show influences on patient flow through the spectrum, as well as the influences on the delivery of appropriate services. Of course, individual, family, community, and policy contexts all play a role, as well as the key box of interest on the upper left, health system characteristics. These include both characteristics of the individual organizations, as well as characteristics for the networks or the systems themselves. So on to our study. The setting for the study are 4 HIV service area regions in Florida. According to the Florida Department of Health, an estimated 130,000 individuals are living with HIV/AIDS in Florida, and Florida ranks as the 2nd highest state for number of new HIV cases. The Florida Department of Health operates as a centralized health department with staff employed across the 67 county health departments. For HIV/AIDS planning and funding, the Florida Department of Health divides the state into 14 single or multi-county areas, each of which has regional staff based in the county health departments who are responsible for training, contract management, and program monitoring. Additionally, the county health departments often serve as a lead or coordinating agency for the regional network. For this study, we have identified and recruited 4 areas to participate, shown in this map. These 4 service areas represent populations with a range of 1.3 to 2.5 million, and the number of counties and county health departments in these areas ranges from 1 to 16. 3 of these areas are urban, and 1, Area 313, is a multi-county rural area. In each area, we've recruited what we've termed the community partner, with the assistance of the Florida PBRN and our co-investigator, Dr. Gallardo. 2 of these partners are local health departments, and 2 are regional planning councils, and representing 2 out of the 10 of those in the state. These organizations, created by the Florida legislature, are multi-purpose regional entities that are in a position to plan for and coordinate intergovernmental solutions to growth-related problems on greater than local issues, provide technical assistance to local governments, and meet other needs of the communities in each region. Our community partners have played and continue to play a key role in project development, implementation, and dissemination of results. Again, the partners in each area were identified by the PBRN. The partners have played a critical role in helping the research team learn about the unique features of each network. Each convened an in-person meeting in May of last year to introduce the research team and project to the organizational stakeholders and system members, which is a critical step in our project development. The partners have also acted as advocates for the project in their communities, helping to build buy-in among local and state leadership. And the partners eventually will be asked to support implementation of the survey, as well as assist in obtaining the organizational outcome data from the Ryan White Services report. Now, let me turn it over to Dr. Bevc to walk us through the project methodology.
Thank you, Dr. Porterfield. As she mentioned, we're working with our partners to look at each of these 4 areas as individual network systems of care, so specifically studying the integration between the primary care and public health care within these 4 regions. So taking a step back, when we look at previous studies of integration or linkage measures, they're measuring 2 organizations at a time. And these measures typically describe the levels of integration with no contact through networking, coordination, collaboration, through that integration or the merger based off the Institute of Medicine's report back in 2012. In contrast, what we're doing here, so rather than looking at these relationships as statistically independent, we're beginning to move towards looking at integration and interorganizational connections as statistically dependent to one another. So social network analysis is going to allow us here to examine those relationships among the multiple organizations that provide care across these regions to understand the structural components that contribute to the system's characteristics and revealing hopefully some useful information about these organizations, their characteristics, and the relationships within the larger system. So breaking down some of the project's data sources for this, getting into some of the more interesting pieces here, to help us achieve some of the project goals that Dr. Porterfield mentioned, we'll be collecting data from multiple sources for our analysis. So some of these here you can see are going to be gathered through qualitative data collection methods, as well as secondary data and then also primary data. So our analysis is going to combine both organizational and relational measures, and that will be then merged into a series of social network models. So reading through these, we'll start with the organizational list that's been developed with our community partners. And so with this allows us to take into consideration the boundaries of our networks. So part of this is that we need to be able to define who is within the system, who is in the system, and who may be outside the system. And for this project, we want to be able to include as many organizations, providers, and other organizations that may be serving clients within each of the 4 survey areas, but also our service areas. So to begin, we are doing this through a series of iterations. We've started with an organizational list provided by each of our 4 areas. Our next step is to be able to conduct our follow-up interviews with some of our key informants there. And this is really to make sure that we have the most comprehensive list possible here. Next, our next step, also done in parallel, is the collection of the secondary and primary sources of data. And so we've put our request in and gone through wonderful IRB reviews and discussions regarding the Ryan White HIV AIDS Service Providers Annual Report. So this is a secondary data source, the RSRs, that provide a lot of very organizational level information about aggregated client data. So you can imagine some of the questions that we've received there. But those really provide some vital measures that will be able to help us look at the system and some of those specific characteristics that we were hinting at. This will be followed up by our partner survey. For those of you not familiar with Partner, this is a tool that was funded originally by the Robert Wood Johnson Foundation, and we'll be working with Danielle Varda out at the University of Colorado and her team to make sure that the partner survey collects a lot of that organizational relationship data that we're looking for through the network tool that they've created. So this sounds like a lot of data, and when you remember, but the other piece that you have to remember with this is that when we're looking at each of these 4 service areas and each of the organizations within them, the power of network analysis really is that ability to analyze the relationships of all these measures as they exist within these complex and very dependent systems of care. So it's not one level, but actually multiple levels and multiple relations. So breaking things down, what's all the data that we'll be collecting? Through the Ryan White Service annual service reports, we'll be collecting measures such as the type of provider. These are sort of the basic characteristics of organization, the number of FTEs, the services that are provided, the size of their patient population, knowing that there will be some overlap in terms of clients served, ideally, as well as some of the characteristics of those patients as well. And so the one point here is that a lot of these measures are already predefined by Ryan White's guidance as well as CDC's categories. Another way that we're capturing information about our organizations, again, like we mentioned, was through the primary data collection with the partner survey, where we'll be able to dig down into the funding sources, the types of IT systems that they're using to share and communicate information and service referrals, a detailed list of the services provided, so again, similar to what we'll be seeing and collecting on the RSRs, and then collecting the information on some of the programs and activities that really support the linkage and continuous care. So our list of services here is combined not only from the RSR survey list, but also our interviews and then the group discussions that we've had with our partners. So what we're going for is a really comprehensive set of those services that are going to characterize what is going to maintain continuity of care, linkage to care, and overall, and really our outcome measures at the end of the day. So by doing all of this and collecting from multiple measures, we're able to reduce the burden that we have on our respondents, but also because those RSRs are only limited to Ryan White organizations, it provides us an additional mechanism for those organizations who may not receive funding directly from Ryan White. And one of the caveats here that we should mention, and Deborah and Dr. Porterfield will probably reiterate, is that this is not an evaluation of the Ryan White program, but really these systems of care across these 4 areas. So when we're looking at the systems and the relationships that exist within them, the partner survey is also going to allow us to capture that varying range. This includes referral for services, shared funding, joint programming and planning, formal agreements, as well as several other relational activities that, again, defined by the interviews as well as the guidance and requirements from Ryan White and other funding sources. We're also able to capture the mission congruence between these organizations, whether they share the similar goals and ideals in their objectives, whether they're contributing resources into the system, their level of involvement, perceived reliability, and their general openness to discussion as perceived by their partners. And then lastly, we have our outcome data, which at the end of the day, how does this help reduce or actually increase the proportion of patients with continuous care and reduce the number that fall out of care. We have the RSRs will be providing that proportion of patients with continuous care. And so of the 3 that Dr. Porterfield has mentioned, this is the one that we're really able to capture and dig into through our secondary data. So those that do screenings, the RSRs contain that data, and then there's also that subset of organizations that apply for the viral suppression. So there'll be also with the primary data that's really going to try and capture some of those other outcome measures. These are self-reports that we're going to be having through the partner data, so we are going to have to account and mention that will be inevitably some bias in some of that reporting, but also we're working to continue our discussions with our partners as well as the Florida Department of Health on some of those other measures. So once we get all this data, as it starts to come in, we have two specific aims that we'll be addressing. So the data will come in, it'll be combined into essentially a matrix array for analysis. And with our first aim here, we're examining how the public health primary and community organizations are working together. And they're working together as a system here to identify, link to care, and provide continuous care for HIV patients. So as we address this aim, some of the things we're keeping in mind is that some of the assumptions we have that we'll be testing are that single service providers are exhibiting higher levels of interaction. So for example, that those that are providing only one service are more likely to then refer clients to other services versus those providers that have a greater number of services who are more comprehensive. We expect that they would refer clients at a lower rate than those single service providers. Also, organizations and agencies that share similar characteristics might exhibit higher levels of interaction compared to those with dissimilar characteristics. So if there are organizations and agencies that are about the same size or receiving funding from similar sources, those may be motivators or mechanisms that promote those interactions and relations that we capture, whether it's referral of patients or shared resources or communications. And lastly here, organizations and agencies that participate in the joint community planning are then also more likely to engage in more diverse interactions. So if you talk to people more, then the idea is that they're able to then refer clients and maintain that continuity of care that we're looking for. So essentially what happens in one network doesn't stay in that network, but it exerts an influence on some of those other relational measures that we're capturing across the system. So this really allows us to begin to look at how those actions and interactions begin to vary across the system. And with our second aim here, you can see this is where we start to tie our outcome measures back to these organizational characteristics and network relations. So beginning to look at how organizations and agencies with these higher levels of interactions, again representing multiple relations, how those affect the proportion of individuals that are diagnosed with HIV and able to maintain their continuous care. So we're starting to bring in some of these exogenous variables into the model to begin to look at how they play into these dependent relational structures. And with that, and given our time that we have, I'm going to turn this back over to Dr. Porterfield to take us through some of what we've originally found. But here you can see just some of the other variations and some of the outcomes that we're beginning to look to find. So we expect to see the variation in the numbers and types of relational ties, how those characteristics are associated with those patterns, and then also what if there is a particular subset of organizations that are associated with the continuous care that could particularly be targeted and then replicated or scaled up in other networks as well. Dr. Porterfield.
Great, thank you. So in this final section, we'll provide some very early results. This is absolutely work in progress from the project to date, and provide some notes on anticipated outcomes in our upcoming timeline. So after our May meeting with community partners and other organizations in each area, we developed and disseminated a draft definition of organizations to be considered as part of the system in each area. We settled on a very broad definition of those organizations that contribute to our 3 outcomes of interest. As an aside, and as part of this definition, based on our in-person meetings, we also have a short list of inclusion-exclusion criteria that we, the research team, will be applying to the list of organizations provided by our informants. So now we'll just present some of those descriptive findings of what do these systems or what do these networks look like. So the average size of each system was approximately 29 organizations with a range of 16 to 43. And the types of organizations include local health departments, private practices, community health centers, private nonprofits. On average, 24% of the organizations in each of these defined systems were private practices, and 24% also community health centers. In terms of the services, we found that many organizations serve multiple roles within the system. So here are some numbers here. On average, 56% are certified testing sites, 34% are providing case management, 39% report that they're providing formal linkage services, and 13% are providing housing services. We found that the 3 urban areas had more organizations who provided case management and linkage services than our single rural area. We also were not surprised to find the importance of Ryan White within each of these systems. So on average, 37% of organizations in each of the 3 that had funding under Part A had 37% of organizations were funded. For Part B, that was 19%, and out of the 4 networks, only 3 had any Part C or D providers. So that is just a brief snapshot. Hopefully that gives everyone an idea of the size and the constitution of the networks we'll be studying. We look forward to our next webinar and sharing everything that we've learned about these networks, and hopefully bringing you some findings, as Dr. Bevc suggested, to meet our specific aims and have information about which of these organizations, what organizational characteristics and network characteristics are contributing to our outcome of continuous care. So now we shift to some additional notes about project implementation and our early challenges. So the first that we described is not specific to this project, but general to all systems-based research. So we deliberated as a team with our community partners how to best define the boundary of the network, which included the definition and, again, additional inclusion-exclusion criteria. Most of these are finalized, but several are still under consideration pending our fall discussions. And as Dr. Bevc has instructed us, this is the hardest part about network studies, developing the boundaries and then developing the comprehensive and valid list of organizations which meet the criteria. So we're in the middle of this step. As she mentioned, our starting point has been a list provided by the community partner which we will now proceed to validate with follow-up discussions with up to 5 organizations in this area. So IRB has presented a several-month delay to the project. We have applied to all relevant organizations, several of which designated the project as not human subjects research. However, one of the IRBs has determined the project to require full review. So we just received approval for the follow-up discussions last week, and we will soon be applying in a staged approach for approval for the survey and secondary data requests. So this is a delay that we'll have to accommodate in terms of our timeline, but right now we will stay on track in terms of the overall project period. In the last few months, we've done our best to keep the community partners engaged, but this is also a challenge that we acknowledge. Keeping them engaged and excited about the project despite the delay, and we've tried to have periodic emails and updates, and I hope and I believe we have several of our community partners on the call with us today, which is wonderful. In terms of outcomes of the project, our goals for dissemination and our hopes for policy implementation. So initially we intended and we articulated goals of developing and providing evidence base to support HIV systems of care, structure, and service delivery, developing resources to support practice, and disseminating all of this to Florida practitioners as well as national policymaking bodies. So all of these goals are still intact. However, as the project has progressed, the goals have evolved. So we feel we are advancing methods for measuring service integration. We feel SNA, social network analysis, is a very relevant method for studying primary care and public health integration or any categories of service integration. And we're excited to be working on what feels like frontline research. Also, promoting a systems-based approach to addressing the delivery of continuous care. So from our review of health services research for the field of HIV/AIDS, we understand and recognize and acknowledge the very important organizational level information that has been gathered. But in terms of a network or a systems approach, we think that this project will be making an early and important contribution. And finally, a recent goal is to inform newly required activities for HIV state programs for integrated HIV prevention and care planning. Since this project started, CDC and HRSA have provided new guidance to their respective funded organizations, their grantees, that integrated planning is now required. So we feel we hope our project will be able to provide direct evidence and information to support this new activity. I believe we had some timeline slides. Let me just see. No, well, I can just walk you through very briefly our anticipated timelines. In January and February, we will be conducting our follow-up discussions with organizations in each area to validate our list and elicit further ideas on the systems of care. We hope to move on to our web-based survey using the partner tool and our collaborators at the University in Colorado in the early spring. And then the other piece of data collection is obtaining the secondary data, which for last calendar year won't be available anyway until April, so that would follow shortly thereafter. In terms of dissemination of findings, we have planned continued engagement with the community partners, so a webinar in February and March, and in-person meetings again with each area, repeating the meetings that we had in May of last year, and those will happen in probably late summer or fall of this year. And then we have extensive plans in terms of, again, state and national dissemination for hopefully policy briefs, products to support practice, as well as, of course, academic presentations. I think that ends this part of the presentation. Again, here's our contact information. We look forward to engagement with everyone on the call, and also please don't hesitate to follow up with us. Finally, acknowledgement, thank you so much to the Robert Wood Johnson Foundation and the National Program Office again for supporting the work and inviting us to speak today.
Thank you, Drs. Porterfield and Bevc, very much for that excellent presentation. I think we are now just about ready to move on to the commentary period of this call, but in the meantime, I'd like to invite folks who have questions that have arisen through the presentation to please enter them in the chat box in the bottom right. And after we hear from Drs. Wilson and Downey, we will pose some of those questions to Drs. Porterfield and Bevc. Again, our esteemed panel of respondents, Dr. Max Wilson, the HIV/AIDS Program Coordinator of the Northeast Florida Department of Health, and Jeff Downey, the Ryan White Part A Program Manager, Florida Area 9. Dr. Wilson?
Thank you very much, Ann. I appreciate it. And thanks to everyone for inviting me to participate in this. I have had a very fortunate position in this project to be involved early on in the initial proposal to the Robert Wood Johnson Foundation and in the first year of the research project. But I'm also, as was noted a couple times earlier in the presentation, somebody on the ground who's actually doing a great deal of HIV planning. So I serve both as producer and consumer, and have a lot of skin in the game. So would just like to sort of share a couple of observations from that sort of complex perspective. I think as Dr. Porterfield mentioned, one of the first and I think most serendipitous observations is that the research that was begun here really started essentially about the same time and a little bit before the Joint Centers for Disease Control HRSA guidance for HIV community planning. And in fact, the first stage of conversations that occurred at the community level occurred immediately prior to the dissemination of the most recent guidance and of the planning that we're now engaged in aggressively around the state of Florida on multiple levels that incorporate both Ryan White Part A, B, C providers and prevention. So there's a great deal of joint planning that's going on. And some of that, I got to believe, is a little bit easier and a little better facilitated now because we were all gathered together in these 4 areas, at least, in one room just a few months before we needed to in order to respond to that planning guidance. So from a standpoint of looking at the immediate impact of the research and sort of the social context of the research project, timing could not be better. On a more local level for us here in Northeast Florida, I'll say that there's additional impacts that the research project has initiated and perpetuated a very robust conversation about local resources and local service plans. And I think that's going to continue as we move forward, particularly in collecting data via the partner survey. So that's the questions that we know are going to be asked of us are things that we're already talking about, already thinking about. And we've done a really good job, I think, of stretching outside of our comfort zones, those of us who work in the core Ryan White world and the core CDC directly and indirectly funded prevention world, to really think about the whole system of care. So having folks come in kind of as outsiders, and there's insiders and outsiders involved in both of the project with respect to the local Florida communities, but having folks come in kind of and ask these very fundamental questions has caused us to stop and think about the boundaries, the edges of our system of care, and that's been very helpful. That's been an important thing for us to do. Again, not only just for fulfilling the joint CDC-HRSA planning guidance, but in terms of getting to taking a moment to reflect on our local areas, just in general. 3 of the 4 areas, Jacksonville, Orlando, West Palm, are also participating in the Partnership for Care National Demonstration Project. Partnership for Care is a national demonstration project that is, in my opinion, really the first project that makes good on the NHOS goal number 4 of a more coordinated or better coordinated federal response to the epidemic. This is a braided funding between the Centers for Disease Control and HRSA that establishes HIV clinics in FQHC, so federally qualified health centers, that are really HIV primary care clinics outside the Ryan White system. So they're HRSA funded, but not Ryan White necessarily. And then the Centers for Disease Control aspect of the braided funding is to provide health department resources such as disease intervention specialists and surveillance personnel that are either dedicated to or in some instances embedded in these new HIV clinics, these new HIV systems of care, which is a really cool approach, and we think the future of system of care and the approach to the epidemic. What Eye to Eye is doing is really coming along at a time that allows us to assess the impact of that new resource and that demonstration project on the rest of the existing Ryan White and CDC directly and indirectly funded system of care. And that's really cool because the evaluation project for Partnership for Care really didn't cover that well. It's a very sophisticated evaluation project that I've also been involved with in the early stages of that program. And the one thing we didn't have is really a good study of that project from outside, so an outsider's point of view on the local level, looking at the total impact on the partnerships and the networks, which I think is a really neat perspective. The last point is that I would point out, just talking about the research and, again, its impact in context, the flexibility and the dynamic nature of the research project to this point has really been exemplary, in my opinion. 2 years ago, when I think this idea was first hatched, I'm not sure that we, as a community in the epidemic, were as closely conscious of or beholden to the continuum of care outcomes. And this project has very much shifted along with our collective focus to align at looking at those particular outcomes. So the outputs that we're going to get from this research that look at the network level impacts are going to be usable and translatable in the same language that we're using to describe other levels of impact and to look at and the other ways that we look at our systems of care. So that's it. I don't want to take too much of Mr. Downey's wind.
Thank you, Dr. Wilson. Mr. Downey?
Hi, thanks for having me on the webinar. I'm really happy to participate. Having been involved in social network research project myself has, personally given me the opportunity to kind of look at similar questions from another vantage point and another lens. So some of my comments are going to be related to related to the methodology and some of the challenges behind that and how I think your project is addressing them. And then I can also share a comment or two about integrated planning and integration between primary care and public health. But regarding social network surveys, in my experience, I had found that collecting relational data through surveys can be very difficult, and unless you have people on the ground who are familiar with the respondents, the individual respondents, and the organizations, it's really hard to get to get high response rates and reliable data. So I think this project, in working with the local partners over the period of time that you are, I think you're in a really good position to avoid a lot of those kinds of issues. Something else that I've found challenging is also getting responses representative of an organization. So if you have a large organization with multiple divisions and multiple levels, questions about who actually fills out the survey, can really impact the kind of responses that you get. So for me in particular, that's been challenging. One way I've looked at addressing that is using archival data as well and other qualitative data, which I believe you're doing here too. So I think the limitations around social network surveys are something that can be challenging, but I think are being addressed pretty well here. The second comment would be, I guess, also somewhat personal, but that relates to how social network analysis can be used in practice on a practical level. So one of the strengths I think social network analysis brings is the ability to visualize complex and multiple relationships. And where an example of that is and I think the project also provides an example of that, is where there's multiple funding streams and multiple organizations being funded by multiple funding streams. It's very hard to sometimes get your arms around what that looks like in a community, and that changes from year to year. So one of the things I'm working on now is collecting data so that I can look at the service category level for each agency, where they're receiving funding and in what amounts, and how that changes over time, and also related to that is how it changes within a given grant year. So if services are being underutilized and there are changes to the contract to reduce the amount of funding for that service, how do you represent that, and how do you represent that at the level of the whole network? So so part of the challenge, I think, is just having familiarity with social network software and the measures and concepts around that, but also just having access to the data. So in a practice kind of setting, you'd almost need to have either a data management system or a means of collecting it so that you can plug it into social network software and get the kind of visualization that you can then share with community partners. But it also gets a little sticky when there are other sources of funding for a particular service. So for instance, in Palm Beach County, we fund mental health services in one of our agencies, but we also have local funding and for mental health and state funding for mental health services. And when we do allocations for mental health in Palm Beach County, a lot of times it's in isolation from the broader mental health system of care. So I believe there could be some usefulness for social network analysis and visualizing these other systems of care that sometimes interact with Ryan White or HIV. So when we're looking at allocation processes and under other funding streams, being able to visualize that, I think, can be very useful. Regarding the integrated plan process, one thing I've learned recently that I find interesting is that there's a distinction between integrated planning and having an integrated plan. So I was at the HIV prevention conference a couple months ago in Atlanta, and there were some presentations, and this actually came up in a presentation that Broward County did. And listening to it, I realized that there are some differences in areas in Florida and probably around the country in how how we approach the integrated planning process. So in Broward County, the prevention side and the treatment side came together to create, and they're still working on it, but came together to create an integrated plan, but the planning processes themselves are kept separate. And in Palm Beach County, we're working on our local chapter for the statewide integrated plan, but we're going a little bit farther in terms of integrating the planning processes. So it's not, we didn't stop at the planning document, but we're looking and having discussions around, how we share data, or how we come together in our respective planning committees, and how we how we analyze outcomes in our 5-year plan. And so I think that that might represent like a higher level of kind of process integration. I don't know, I couldn't say that one approach is better than the other, but there may be differences across study sites in this study that might be worth addressing. I guess one final point I'd say too that I found interesting in Florida is just some of the differences between the governmental public health system, and this is I'm speaking particularly about Ryan White, but differences between actors who are tied to the governmental public health system and those that are not tied to that. So, for instance, in the EMAs, the Part A organizations are tied to the local county executives. So we're we're designated by our local county commissioners. We're the designated agency to be the Part A entity, and it's the same in the other EMAs where our state health department partners are part of the state system. And so why this is interesting is because it sometimes gives us different roles depending on the issue. So for instance, during Affordable Care Act implementation, our partners in the state health department and our local health department office of the state health department, a lot of times were constrained in what they could do and how they could act around ACA implementation. And so the Part A's took on a bit of a different role since we didn't share the same constraints that our colleagues did. So it lent itself to some really interesting situations. But I guess the point is that different actors in a local network are constrained in what they can do in one way or another. And I don't know, maybe Florida is more interesting than other states, but it just kind of struck me that, like in other states that I've worked in, where local health departments have been completely independent, it seemed that there was not a lot of accountability for results. And I had always thought that state systems that were more centralized would lend themselves to greater accountability. I think in a lot of cases that's true, but depending on the context, it could also result in negative outcomes at some point in time. But so I don't know if that would have much bearing on some of the questions that you're asking here, but I think the point is that depending on how the actor is connected to other actors in the vertical dimension, it could have an impact on how on what roles they take, depending on the context that you're looking at. So I guess I'll stop there. I had a couple other notes, but maybe we can share those offline.
Thank you so much. I'd like to give Dr. Bevc or Dr. Porterfield an opportunity to respond to any of the issues raised by Mr. Downey or Dr. Wilson earlier.
Well, this is Deborah. I'd just first like to say thank you. Thank both of you for your time today and the input you've provided. I think it's obvious to us and everyone on the call how fortunate we are to have you both and others, our other community partners, as our partners in this project. And the level of engagement and the input that you provide is critical to this project being able to answer any questions that are relevant for practice. So I'm very fortunate we are, and I'm sure that's obvious to everyone on the call. Just very briefly, I'll say, Jeff, your last comment about the funding, and as you know, that's very much a question of high interest. Which organizations are funded by which funding streams? What do the maps of that look like? And what relevance does that have in terms of some of those research questions? So absolutely, that is a key policy piece of this whole project, recognizing the relatively siloed funding, which maybe is beginning to break down, but what impact does that have? And then just very briefly, I'll go back to, Max, some of your comments. As a former physician in an FQHC, I was really interested in the discussions that happened in each of the 4 areas about the importance of FQHCs historically and looking into the future, and what are the positions of those clinics within these systems, and is it optimized, or is that perhaps something that we will learn, at least in these 4 areas, is not yet optimized, and what could happen to strengthen the role of those clinics in the overall system of care. So I'm really excited that turns out to be important questions that hopefully we can begin to address. So those are just tiny comments, but again, circling back, thank you so much for participating on this call and also for supporting this work.
Absolutely.
All right, the floor is open for additional questions. If you have any questions at this time, please go ahead and enter them in the chat box on the bottom right-hand corner. And while you're thinking of those, I have a question for Dr. Bevc. I was very interested in one of your method slides when you talked about assessing mission congruence. And I was wondering if you might talk a little bit more about your process for looking at how congruent various organizational missions are through this project.
Sure. So the term here, when we refer to mission congruence, what we're looking at is whether organizations or agencies share a common vision in the end of what they're working towards, that they're essentially working towards together to accomplish. So in this case, we're going to be asking on related as it relates to our project goals here. So I have to flip back to the project goal side, but where we're looking at that linkage to care, and to what extent do organizations, is that part of their mission or their goal of their organization to be able to get clients from one point, from whether it's testing or counseling, into care, to whether they receive that within the 3 months or the 6 months, being able to get to other organizations that would be able to provide them services. Or if there's an organization that's providing housing services, is their mission necessarily aligned with linkage to care for patients? And that's an example where perhaps the mission congruence may not be as strong. So we're going to be capturing that with some of the relational measures as a perceived measure. So for each of the organizations that we'll be surveying, we're also asking about their perceptions and their relationships with the other organizations across the area. So in the case of Mr. Wilson's organization, as his role, as he views the other organizations across the region, how does he view their mission congruence? So does he see that he believes that their mission may be aligned or may not be aligned? And then this goes to what Mr. Downey was saying about the importance of making sure that we're talking to the right people, because one person's perception may be quite different from another. And so that's where going through this iterative process of being able to make sure that we have the right organizations and we have the right contact within those organizations will help us make sure that we're capturing that relational information that's as accurate as we can get it to be. So,
thank you so much for that. I think it's clear that this is really important work, looking at aligning across systems and across sectors. And I think, as I mentioned at the top of the hour, that this work is becoming increasingly important, and it is central to the new Systems for Action national program of the Robert Wood Johnson Foundation. So I want to thank again our terrific guests, Deborah Porterfield and Christine Bevc, as well as our respondents, Max Wilson and Jeffrey Downey, for their insights. This has been a really fascinating hour. I would like to encourage folks to look at our upcoming webinar list here, find ones that are of particular interest to you. As you can see, we have leveraging a health information exchange innovation to improve the efficiency of public health disease investigation coming up in about a week. We have interorganizational collaboration in local public health systems coming up at the beginning of February, and then a week after that, implementation and diffusion of the New York City Macroscope electronic health record surveillance system. These are all going to be excellent research in progress webinars. We hope you'll join them. We hope you'll check out our archives. You can see the link at the top of this slide. Again, thanks to our presenters and respondents, and thanks to all of you for attending. We look forward to seeing you next week. Thanks so much.
Thank you, everyone.
Thank you.